Hello everybody, I think everybody's coming in for the session. Okay. Right, it's 1:01, so we'll start off today. So welcome to our latest in our CQC Well-Led Series webinars. It's good to see so many returning colleagues, and we've got a wide range of providers present today from the NHS, but also from private GPs, dentists, care homes. And so it's really good to see a wide range of providers. And this webinar has been as popular as any of the others we've done, and we've had over 220 registered for today. So, really excited to have so many people that are interested. My name's Gary Hughes, and I'm sitting in for Claire Sieber today, and I'm joined by the rest of the Well-Led team for the webinar. And we're also pleased to be joined by our partners from the Medicines Management team today. We'll be coming to them at the end, and we'll introduce them shortly when we do all our introductions. For myself, I've worked with the Well-Led practice for over a year now, and supporting practices and PCNs to help them get the most from the platform, but also improve in terms of their leadership skills. I've been in primary care for 16 years. 13 of those years was as a practice manager, and I've been a PCN board member and a federation director. So today's webinar is the 6th in our series of CQC webinars. Now, each webinar has focused on one of the quality statements that sits under the Well-Led key question. And today we're going to look at the quality statement called Partnership and Communities. The recordings of all of the previous webinars are available on our YouTube channel. And this webinar today will be put on the YouTube channel as well. And at the end of the webinar, we'll send you details of that and how you can get to this recording, and also how you can access the slide deck from today. You'll notice that the slides that we're using today are quite text heavy. And the reason we've done that is just that we want to share as much information as possible, and also that they'll be helpful to you afterwards as well. So they're quite text heavy slides, but there is a reason for that. Now, as we go through the webinar today, we'd love to take any questions. So please use the chat for any questions that you've got. We'll try and answer them as we go along. But if not, we have a Q&A session after the main presentations where we'll take any of the questions then. But you can also at the end use our feedback form to direct any questions to us, and we'll happily answer any on email as well. And if we do run out of time and there's lots of questions, we'll make sure we come back to you on email. So one way or another, if there's any questions, we'll absolutely be answering those for you today. Next slide, Ben, if you can go on to the next slide. So let's just go through the agenda for today. So we're going to be covering the quality statement of partnerships and communities. So Gabby, our CQC expert, is going to talk through what that actually means, and she'll share evidence from recent inspections of GP practices and care homes, and what seems to be ticking the box for good, requires improvement, and the inadequate box. We'll then be putting some hot seat questions to our panel, as we've done in previous webinars, just to help to bring some of this to life with some context. And then we'll move on and share some information about the Well-Led platform and how it can help you in terms of meeting the CQC Well-Led question, but also wider leadership development. And we'll take any questions from you, as I say, when we finished our presentation. If there's any questions, we'll happily take those. And at the end, we'll be handing over to the Medicines Management team, and they'll be able to share how they're helping practices, federations, and primary care networks with tailored services to improve and enhance patient outcomes. So let's go on to our introduction. So next slide, Ben, if you would. As I say, we're joined by a number of people today in the Well-Led team. So first, Gabby, do you want to do just brief introductions of our name and roles?
Brilliant, thanks Gary. So hi everyone, I'm Gabby. I am a previous CQC inspector, so I've worked across adult social care and healthcare for nearly 15 years now, and I was a CQC inspector for about 4.5 of those. So I now work for Let's Make Lemonade, and I'm an associate supporting with CQC mock inspections and CQC compliance for the well-led practice and provider.
Thanks, Gabby. Ketan? Ketan,
Hi, I'm Ketan. Yep. Hi, hi, I'm Ketan. I've been a GP partner for 16 years. I'm also our GP Federation, one of the directors, as well as a mediator.
Thank you, Ketan. Farhad and Mohammed, do you want to just give a very brief introduction?
Sure. Hi, my name is Fahad. I'm the Operations Director at the Medicines Management Team. I'm an advanced clinical practitioner by background and a pharmacist. And I've been the director for 4 years now, just overseeing the operations of the business.
Hi everybody, my name's Rashad. I'm a director of the Medicines Management Team. I do a lot of training, upskilling of our pharmacists at the training hub. Nice to meet you all.
Thank you. Right, okay. Well, now we've done introductions, let's go straight into the main purpose of the presentation. So I'm going to hand over to Gabby, our CQC expert, and she's going to guide us through partnership and communities. So over to you, Gabby.
Thanks, Gary. So for anyone who has not been to one of these webinars before, or for those who have, you'll recognise these first 2 slides that we're just going to run through very quickly. And what we do behind the scenes is we capture the data of the number of GP practices and care home reports that have been published this month, but also we're totaling up over the year as well. So we can see the proportion of adult social care versus healthcare services that are being inspected by the CQC, and also the ratings that they get. So as we can see very quickly here, we're still seeing a very low number of services that are receiving an outstanding rating. Good to see actually that the number of good services has increased from previous webinars and previous data that we've captured, so the proportion of that has increased. You don't necessarily know the reasons for that, but it's positive to see it. And as we can see, actually there requires improvement or inadequate services from a statistic point of view is similar across both services, although obviously the number of adult social care services that are being inspected is much higher than the GP practices. So we only had 14 GP practices that had their reports published this month. It is really important to remember that although they were only published this month, they could have been inspected a long time ago, especially with services that are have enforcement action being taken against them, or there are any breaches of regulation. Sometimes it can take 2, 3, 4 months before the CQC are able to publish a report. So these numbers aren't indicative of what was inspected last month, but just what was published. And these are all available on the CQC website for you to have a look through, and something that all of us encourage providers to do regularly is to browse through services within your sector that have been rated outstanding or have been rated requires improvement or good, and you're able to then pick examples from that and kind of learn some lessons from that and discuss it within your team. So that's a very similar approach as Gary's explained that we're taking today to hopefully share some good and not so good examples with you. So the next slide that we've got, as I mentioned really quickly, is just 2024 so far. And towards the end of the year, we'll be able to see the whole 12 months worth of data. Again, a huge amount of care homes are being inspected and reported upon compared to GP practices, although in the grand scheme of how many practices and care homes we know are out there, still feels relatively low. So worth bearing that in mind. So if we move on to the good stuff, the partnership and communities, go into the detail. So we've got here, what I've tried to do today is to break down the quality statement into 3 different elements for us. So we can see that the CQC have made this quality statement to say we understand our duty to collaborate. So collaboration is one key word we're going to focus on, and partnership, so that our services work seamlessly for people. We share information, so sharing is another one that we're going to focus on with partners, and collaborate for improvement. So that integration between health and social care, so the partnership working is another area that we're going to have a look at. So throughout the presentation, you'll see some key top tips and examples from a sharing, an integration and a collaboration perspective. In terms of legislation, the good stuff, the stuff that we all need to be familiar with, because as we talked about before, the CQC model may have changed in the last couple of years, where we've introduced the quality statements and the evidence categories and the scoring system, but what hasn't changed are the fundamental standards and the regulations that sit beneath it. So we talk about the quality statements, but what we also try to do is embed learning in line with the regulations and the fundamental standards that hopefully all of you are familiar with or can take time to familiarize yourself with after this presentation. So the three key fundamental standards that we're looking at are good governance, which is Regulation 17 under the Health and Social Care Act, safe care and treatment, which is Regulation 12, and person-centered care, which is Regulation 9. Regulation 17 you always see under well-led. It's the kind of the building blocks of being well-led, is to have good governance, but it's always really interesting to see what the other key pieces of legislation are that the CQC have selected to fit under this. So we've got safe care and treatment. We're thinking about the safety, we're thinking about risk management, we're thinking about risk assessments, we're thinking about how we're working with people to understand how to take positive risks, how to keep themselves safe in the community or with their own treatment plans. But we're also looking at person-centered care and how you as a provider are really making sure that it's not always processes that are driving the approach for working with people, but it's actually getting to know them, understanding individual circumstances, and as a result having a good governance, and then being able to demonstrate person-centered care and partnerships and communities. So if we move on to the next slide, please. Thank you. So what we've done here is we have got, as I mentioned, we've got the regulations, the three regulations that underpin it. So this slide here is Regulation 17, the good governance regulation. And what I've done is extract some of the information from the legislation into a slide for you each. So you will have a slide for good governance, you'll have a slide for safe care and treatment, and you'll have a slide for person-centered care. So here are some examples of how the regulation complies with or aligns with the quality statement. Is that the CQC are specifically wanting to see that you are seeking the views of a wide range of stakeholders. So as we know, stakeholders includes people who use services, so patients, residents, service users, people, whatever we're going to call them today. We've got staff, visiting professionals or other professional bodies that you work with. This can include commissioners, it can include local groups, so people with lived experience, members of the public and other bodies about their experience and the quality of care and treatment delivered by you. Another example from Regulation 17 that is really important is that all feedback should be listened to and responded to as appropriate, and it should be analysed and used to drive improvement for the quality and safety of services. So again, if you look at that, we're thinking back to the regulations quality, so person-centered care and good governance, and the safety is the safe care and treatment. And we want to see that people are having positive experiences of engaging with you. So when we're looking at seeking feedback, when we're looking at complaints and compliments, when we're looking at opportunities for them to let you know their experience of the service, it needs to be a positive journey. So even if the feedback itself is a positive, the actual journey of providing feedback, feeling that they've been heard and listened to, and that their queries or concerns have been responded to, and that lessons have been learned, that should feel like a positive and seamless experience. So that might make you want to kind of go back and have a look at your complaints policy, your quality assurance policy, your compliments or receiving feedback process, whether that be on your website, whether that be on paper slips that you have, within the service, text messages that are sent afterwards. There's obviously a huge amount of ways that you can receive feedback, but it's really making sure that that process is seamless and positive for the person. And then we've also got an interesting one here that isn't necessarily talked about very much, but I think it's really important to think about, is where relevant, the provider should also seek and act on the views of external bodies. So this can include fire, environmental health, royal colleges or other bodies who provide best practice guidance. And we'll talk about this a little bit more later, particularly when we go to the hot seat. But what we often see and what we don't want to be seeing is that registered managers, practice managers, other members of the teams, they can hold a lot of information or a lot of worries or concerns or potentially, inability to complete certain tasks, they can hold it quite close to their chest, and they're not always asking for help or seeking guidance from other experts. And that's where things can go very wrong. So from a CQC point of view, as an inspector, I was always asking, and I'm always asking now on mock inspections, who else are you engaging with? You can't be an expert at everything, and that's okay. You shouldn't be. No one's expecting you to be, but it's how you feel kind of confident and open to say that, talk about that, and do your research to make sure that you're then engaging with the best quality of external providers as well, or external colleagues as well. So that's a little bit of Regulation 17 for you. So if we move to the next slide, please. This is having a look at Regulation 12, so safe care and treatment. Again, we've got here that the provider must actively work with others. So you'll see that there's a consistency of themes that happen across the 3 regulations that we're looking at, both internally and externally, so that the treatment that people receive remains safe. Really important to consult with nationally recognised guidance. For anybody who's recently registered or is undergoing registration process at the moment, you'll know that the number of policies that the CQC require is quite extensive, and one of the things that they are looking at is how recent and relevant the guidance is that you're incorporating into your policies. So if you've got a safeguarding link to a completely different local authority from 2006, then that will be picked up on. You need to be really clear that the information you are referring to, the hyperlinks that you're using, any training that you deliver to your colleagues, it's based on up-to-date and nationally recognised guidance. And if anyone has a question of, okay, what is the nationally recognised guidance, the CQC provide that information for you. So on their website, under the quality statements and under the regulations, they do then provide the best practice links. So they will tell you who is nationally recognised guidance. Another example is that the outcomes of investigations into incidents must be shared with the person concerned, and where relevant, potentially their families, carers, advocates, and it would also need to be shared with other stakeholders, professional bodies, where relevant, as we know, for example, with safeguarding or environmental health outbreaks. So this is also in keeping with Regulation 20, the duty of candour regulation that we all have a duty to adhere to. And a final example, which is again really important from a safety perspective, is that ultimately any registered managers, the registered providers who are on this call, you must remember that you retain legal responsibility. So although you can delegate responsibility through contracts or legal agreements to a third party, ultimately it's you that will be held responsible, and that you needs to be responsible for quality assuring and quality checking the people that you're working with, and making sure that they are also working with nationally recognised and up-to-date guidance. So it's a little bit of doing your homework, making sure that you're working with the right people at the right time, taking on their knowledge, taking on their learning that they're giving to you, and as a result building a better, more safe and person-centred service. And then last but not least, the next slide looks at Regulation 9, which is, oh there we go, which is person-centred care. So again, providers must work in partnership with the person. Sounds obvious, but it's something that the CQC are looking for, and something that we don't necessarily always see when we are out doing our inspections. So, and really taking a moment to think about what that means, partnership, working with the person receiving the care or the treatment, having a look at what your co-production strategy might be, what your patient participation groups look like, what your feedback process looks like, the time that's given to dedicated to actually listening to people and working with them, particularly if we're thinking about initial assessments, referral processes, communication preferences, all the individual things that enable a positive journey for a patient or person receiving care and treatment must be considered. And then another example is where providers share responsibility for providing the care and treatment with other services through partnership working, such as integrated care, multidisciplinary assessments, which I imagine everyone on the call is dealing with at some point or other. They should take into account the information from all relevant teams, staff and services. So again, what we don't want to see is, even if you are doing the first right step to collaborate, to do those assessments, if you're not then taking into account the information that's provided to you, and as a result you're not learning from it, you're not delivering safe care, you're not delivering person-centered care, and ultimately you can't demonstrate that you've got good governance. So you'll see that the partnership and communities is really, really key to, you know, to being able to show the CQC how you are delivering care that's person-centered, that's safe for people, and that your policies, your processes, and your governance systems behind the scenes all hold that up for you. So if we move on to the next slide, we've got examples. Again, for those who have been part of these webinars before, or for anyone that hasn't, just for reference, we take extracts from recent CQC reports that have been published. Anything that's in orange or red represents a requires improvement or an inadequate rating. Anything in green represents a good rating, and anything in blue represents outstanding. So part one of this partnerships and communities quality statement, we've then got some examples from reports of a service that was rated requires improvement under this particular area. So the CQC is saying staff and leaders are open and transparent, and they collaborate with all relevant external stakeholders and agencies. So the CQC have commented on this particular service. People told us that staff and managers worked with health professionals and supported them with appointments, and that they saw records of health appointments and referrals taking place. So the governance seems to be there. People spoken with had a clear understanding of their health conditions and the treatment they received. So we can see person-centered care is there. However, one visiting professional then fed back to the CQC about a specialist diet that was needed to reduce the risk of choking. And the staff member that they spoke to, who was delivering care to that person, was unaware of this. And there was no evidence of that staff member or the wider team seeking additional external guidance. So if we go back to the three elements that we've spoken about, we've got that the initial statement demonstrates person-centered care because people had a clear understanding, people have been collaborated with, people feel involved. We've got initially from a governance point of view that the managers are working in an integrated way, but what they're then not doing is working in a safe way, because the risk that's been identified by another professional hasn't been addressed and isn't being dealt with within the service. So if we're thinking about it from a triangle point of view, which anyone that's ever worked with me, I spend a lot of my time talking about a triangle approach to join up the thinking. You've got, if you want to think about it like regulation 9, 12 and 17, if you want to think about it from an integration, a collaboration or a share point of view, this particular provider has only ticked 2 out of the 3 areas, corners of that triangle. So that's why they requires improvement in this area rather than good or outstanding. So if we move on to the next slide, we've got another example for you. So this here is a service that has received an inadequate rating. So the CQC here are looking for staff and leaders work in partnership with key organisations to support care provision, service development and joined up care. So the practice had a vision which was displayed on their website, which stated, "We aim to provide the best possible outcomes for our patients. We will seek to collaborate and work in partnership to strengthen community links and respond to local, regional and national initiatives." So from the outside, that sounds fantastic. If we're thinking about, if we go back to that triangle, potentially if the CQC inspector was reading that in advance, they might think, great, they've got really positive governance processes in place, they work in a person-centered way, and safety is at the top of their mind. Fantastic. But the CQC have then reported that when they were on site or when they undertook the inspection, we found limited evidence of contact and working in partnership with community services. So it's immediately all fallen down. So it's all very well to have lovely mission statements, lovely values, lovely business plans, development plans, agendas, all of the nice stuff that we like to see from a governance point of view. But if there's no evidence of it, and if you're not doing it, you're certainly not delivering person-centered care or safe care and treatment. So just something to think about. Always try and join up the triangle, whatever you're doing. If we have a look at the next slide, please. So this here is part 3, the final part for this particular quality statement. And this here, the CQC are looking to see that staff and leaders engage with people, communities and partners to share learning. So here, that key thing there, share learning with each other that results in continuous improvement. They use these networks to identify new or innovative ideas that can lead to better outcomes for people. So this service here, you can see it's in blue, which means they received a rating of outstanding very recently. It's a bit of a long-winded one, but it's worth talking through. So prior to the implementation of the total triage, so a system that they've introduced, the provider worked with a group of patients to test the system and seek feedback and suggestions. So fantastic, person-centered care being really well considered there. Additional sessions were then held where patients' service assistants worked with patients in a role play scenario to fully test the system and identify any improvements that can be made. So there you've got person-centered care, you've got good governance, and you've got safety, all being considered through one role play experience. For example, so the CQC heard examples from staff and patients. So multiple stakeholders have verified to the CQC that this is working, of changes the provider had made in response to feedback. For example, the number of questions on the triage form had been reduced. So that might be because patients fed back about accessibility, about understanding or feeling that they can be involved in the process. It might be because staff felt that the questions were too onerous, that they took away from the task at hand. There could be multiple reasons why they had to be reduced, but the main thing is that that's what people have said needs to happen, and the provider has listened and done it as a result. So another example was they've introduced a dedicated option for other healthcare professionals to contact the practice. So we're thinking there, that's fantastic. They're doing integration work, they're collaborating with other providers. And the colouring on the form had been changed to make it clear for all patients to read. So again, fantastic. For anybody that knows about the accessible information standards, then that's really the requirement that all providers, well, not all, but providers need to make sure that information is accessible for individuals. Then that's positive that they've taken that on board, so that there can be no, individuals who are affected who might have communication needs. So this quality statement, it sits under well-led, but actually within the CQC report, it comes from both the well-led and the responsive quality statement. So they were picked up across both key questions, because it was also mentioned under the listening to and involving people quality statement, which sits under responsive. It was also mentioned under learning culture, how staff and teams work together, and partnerships and communities. So this one example that they have introduced and the way in which they've done it has actually then enabled them to receive outstanding in 2 key questions. So it's really positive to see. So underneath, sorry, you've just got 3 other examples. So the provider had a schedule of regular meetings which enabled them to review information such as capacity and demand for appointments, complaints, significant events and feedback, systems for review of information at local level, which was then reviewed by the medical director and the board if needed, and the provider also carried out in-house patient surveys to obtain feedback. So really positive examples that we've already touched on about collaboration, integration and sharing good practice. Hopefully that's some food for thought for everyone on the call. Next slide, please. Okay, so I won't go through all of these, but as Gary's mentioned, the next 2 slides are quite text heavy, but hopefully they are something for you to take away and read in a little bit more detail. As I've mentioned, I've spoken about the quality statement being broken down into 3 areas, so sharing, collaboration and integration. So what I've done is extract 6 examples from those 3 areas that I have seen whilst out on mock inspections this year. So they're relatively recent examples that we can draw from, and those services are sitting with good ratings. So there's no concerns that have been raised about these examples. So we'll just pick one from each to talk through. One GP practice. So actually, if anyone's on the call and you recognise this as your service, then thank you in advance for your inspiration. So one GP practice that I went to recently, I observed at a team meeting discussions between staff about the Pharmacy First initiative that I'm sure everybody on the call is familiar with, that had recently been launched. And what they had been asked to do was provide feedback at a national level. So this wasn't coming from the ICB, it was coming from higher up. And there was a fancy slideshow and a fancy box that they had to complete with what was going well and what was not going well. And that was sent off. But the conversation very quickly led to not necessarily having a clear understanding of local processes, how local pharmacies were working, and how that could impact on their day-to-day business. So the registered manager and I spoke about that, and we agreed that it would be beneficial for them to reach out to their ICB to initiate discussions between all of the GP practices within that particular patch and the pharmacists as well, to see if they could iron out any confusion or any questions that were happening. That's an example of where it is all very well providing national feedback, but as we know from working in this sector for long enough, it can take a very long time to reach national, and it can take a very long time to come back down again before we hear anything. In the meantime, what the CQC want to be seeing is, what are you doing about it on the ground, so to speak? So how are you working with your neighbours to address any questions that you might have? An example from integration was that one residential home had worked with local students at local colleges who were studying media to help with support plans to ensure that they met the accessible information standards. So this was a service supporting people who had a learning disability, and they had all, they'd done some co-production work and agreed that actually having care plans that were based on using video formats, sound recordings, moving images, everything like that would be much more beneficial for people. So the media students actually then helped to create those with the residents at that particular home. That's a really positive example of integration, thinking about partnership working, thinking about person-centered care and safety as well, because it's all very well having a nice care plan, but if the people whose care plan it is can't read them, can't understand them, can't use them, and can't contribute to them, then it's just words on a paper. Essentially, it's not what we want to be seeing from a quality perspective. And then an example of collaboration was that one GP practice had texted all of their patients to submit feedback that would be discussed at their local patient participation group, rather than having to either be a member of the PPG or feel their feedback was not heard in the right forum, or simply hearing about the feedback afterwards. See, I personally have not come across that before. Normally what I see from PPGs is that you're either a member, you're either kind of within that and you're contributing towards change, and then the patients are simply told afterwards, okay, this is what we've done, this is what we discussed, this is what's happened. But this was almost an additional layer to that. So it's, if you don't want to be part of the PPG because that, that might be a little bit too much time, or it's not something you're interested in, that's okay, but you can text feedback in, and that will all then form part of the agenda for the patient participation group. So it was an additional layer and a way of getting feedback that I personally have not seen before. If anyone else does that, that would be fantastic to hear about. But I thought that was really positive from a collaboration perspective. And then if we move on to the next slide, please. We've got 6 top tips. So again, I won't go through all of them, but a couple from the sharing, integration and collaboration perspective. So from sharing, I do say this a lot. So if you've been on these webinars, apologies if you think this is all I say, but I think it's really important. So ensuring that lessons learned as a topic forms part of all meeting agendas. So whether that be if you have whole team meetings, if you have reflective practice time set aside, if you have training afternoons set aside, if you have clinical meetings only, reception meetings only, office staff only, or the whole team, whatever it is that you're doing, please ensure that lessons learned is part of the agenda, always and forever. Even if there aren't any lessons learned that you think have happened that month, it's really important to have it on the agenda, because it will encourage staff to think, are there any lessons learned? Is there anything we could have done better? Actually, one staff member might say, oh, I'm not sure about that, I didn't think this worked well, or oh, we really enjoyed this new thing that we've introduced, or we heard from someone else down the road that they're doing this. There is usually always a lesson to be learned, even if it's very, very small, and it can feel a little bit like pulling teeth if it's not a regular discussion that you're having. But the more that you talk about it, and the more familiar it becomes, and the more it becomes part of the everyday language that you use within your service, the more that you will find that these conversations are flowing more easily, and that you will pick up on ways to drive improvement. So it's something that I like to see on all different agendas. An example from integration is that considering your policies reflecting local systems and processes. So again, if you've gone through the CQC process recently or you've had a CQC inspection, you need to be making sure that your policies reflect local systems. If you're bulk buying your policies, so specifically probably this is more aimed at independent doctors or adult social care services, but if you're bulk buying your policies, that's fine if they can contain national information on things such as safeguarding, or probably an example of safeguarding or mental capacity details. But what they won't know and they won't have for you is your local details. So you need to go in and make sure they're bespoke. I've seen lots of policies that you click on the link for who to contact to raise a safeguarding alert, and it just takes you to a blank page, or the hyperlink doesn't work, or actually it's a historic, it might be a previous local authority that you worked with, and boundaries might have changed, you might have changed and taken your policy with you, but it's not been updated. So thinking about if your medicines policy is looking at pharmacy or contact details for other GP services, thinking about making sure that they're up to date. Again, we've clicked onto GP practices that they integrate with or that they work with, and they're from a completely different area because they might have taken that policy from a friend or a colleague or a previous job role that they had. And then another something to consider is the local demographics. So we know that from the CQC statements that we've talked about in the past, and in particular in this one, what the CQC want to see is, do you understand your local area, your local community? Do you know the people that you're working with? And as we can see from the example of the inadequate or the requires improvement service, it's all very well having a very fancy mission statement or a value statement, but does it reflect your local area? And if not, then why not? So making sure that you're thinking about that would be really beneficial. And then last but not least, as an example from collaboration, thinking about how local knowledge, so local people with local knowledge can support you. For example, we've seen inviting people or patients from specific groups to do a walk around. So actually this is an example, but I put it on the top tips because I ran out of room on the other slide. But what one practice that I worked with have done in the past is invite specific patient groups to do a walk around of the GP practice, and they have then provided feedback about the accessibility of the service. So, can you see signs visibly? Do you feel that the area is confidential enough to speak to reception staff? Is there enough chairs and space for you to get to when you're being called to a GP room? Are you clear where you need to go? And they specifically worked with, for example, people who have a learning disability or other communication related support needs, and they then use that to change the layout of the practice. So it's an example, but you can a top tip that hopefully you can all take away with you. So that's me speaking probably a little bit too quickly, but hopefully helpfully, about the partnerships and communities statement. And what we're going to do next is go to the hot seat. So this is where I will ask some questions to Gary and Ketan, questions that I may ask when I'm out on inspection, or I've been a little bit tough and put some tougher questions for them this month, but we'll see what they say. So if we move to the next slide, there we go, thank you. So question number one for Gary. If we look at internal systems, so specifically here we're thinking about internal processes, we know the majority of teams are made up of a wide and varied skill set, and yet a common pitfall as a registered manager or as a manager in a capacity is to only expect staff to deliver in line with their job description. So without recruiting for a specific partnership and communities role, because not everybody can do that, what can managers do to encourage or inspire their workforce to look beyond? And by look beyond, I mean look beyond their job and their expectations.
Yeah, okay. I mean, it's a great question. First thing I'd say is I think the idea of a partnership and communities role is a fantastic idea, but I suspect we're not there yet. But as we move into integrated neighbourhood teams, then I can see that happening. I think it's a great idea. I think for me, if I think back to my time as a practice manager, I think it's about not putting your staff in a box and confining them to their role. I think it's never a good idea to think of the job, the role as the job description and what's in there. And often, it's said that, the job description is just a guide. So I think it's never a good idea. It's better to think of and align the job to the vision and the purpose of the organisation. that can be difficult, but bringing that in to what their role and their responsibilities is, I would align it to that. And when you do things like appraisals, I would be measuring against, the vision and the purpose of the organisation. The other things that I always found successful as well was to make sure that you were developing staff to be multi-skilled. So, making sure that they can do more than one role. It's great for succession planning, as well as them help, to think beyond that sort of job description and what they're doing. And I think if you were thinking beyond the practice, again, as the practice manager, it's easy to think, okay, I'll manage all the stakeholders and the external collaborations, but involve the practice team, introduce them, let them know who your stakeholder partners are and, why they're important stakeholders, and involve them as well. I think that's a good thing. So I think that's what I say.
Brilliant, thanks, Gary. Yeah, that's really positive, and I'm sure that everybody is, again, very familiar with this, but please make the most of your appraisals. They are such a good opportunity to pick apart, as Gary's mentioned, things to considering multi-skilled, looking at making sure that your colleagues are multi-skilled, understanding the vision and purpose not only of the organisation but of your staff. So what brings them to work, what's their purpose for being here, what's their visions or goals for the future, and are they familiar with their job description, but actually is there more to what they're doing? And I think one thing that can work quite well, especially for the multi-skilled perspective, is reverse mentoring. So something I know that the NHS encourage quite a lot, and there's lots of information on the NHS websites about that. But for anyone that's not had a chance to think about it, just simply Google it. There's lots of information out there. But the benefits for trainees with reverse mentoring is that they can share their experience and journey with senior colleagues who want to learn and facilitate important conversations. And then the benefits for the trainers is that you will improve your understanding of your trainee experiences to then improve the quality of service delivered. So that's one fantastic way to make sure that your workforce are multi-skilled, that they understand the different roles, job requirements of a practice. So that can be really helpful on a practical level, but also from a partnership and quality perspective. So Ketan, I hate this saying, but I've used it. So as the saying goes, there's no I in team, and yet we often see providers fall short when it comes to teamwork with external stakeholders. So here we're looking outside of the four walls of our service, so to speak. What are some of the barriers that providers can face when it comes to partnership and community working at local and national level?
Well, there are actually so many I could go through. So I think when I was thinking about this, I thought what I'll do is I'll list some of the big ones, and then I'll pick one, which I think is really important today, particularly in the current climate. So fragmentation of services. You've got different organisations often working in silos. Silos in a system is often a phrase that is bandied about in a big organisation, such as the NHS, for example. Although, we've gone some way to trying to kind of work differently with PCNs, integrated neighbourhood teams and so on. But other ones include resource constraints. It's always about funding, staffing, cultural barriers, language variances that we'll get. Sometimes there's traditional lack of trust, for example, between primary and secondary care, leaning on things that may have gone wrong previously. But I think the one that we come across, certainly in primary care, we come across almost on a daily basis, is that you find different stakeholders have different priorities and different objectives. So we are all in the health setting, but we have different things that we have to achieve. Actually, we're judged differently in terms of whether you've reached a particular target or what that funding should be put towards. And that then ends up in a lack of cohesion in joint efforts, and it can be difficult to actually get an outcome that means something positive for all of the organisations involved. And really, when that happens, it's about bringing people together at the onset of any new problem and actually trying to find where you can align and what are the common priorities that you can actually work on together. Hopefully that then feeds into some level of trust and transparency and a more positive outcome.
Brilliant, thanks, Ketan. Yeah, I think everybody on the call will agree with you that when you are working with different stakeholders who have different priorities, different but also competing priorities, it can be quite difficult to feel as though you're actually coming together. But it only takes one or two things for you all to kind of agree on and for you to have a plan moving forward to get right. Sometimes it's a bit like a house of cards, isn't it? The rest sometimes, well, often can follow in a much more positive and seamless way. So it is about, it might feel like banging heads, but actually it's about bringing heads together and hopefully finding that place to work from that's the same. Okay, third question. I'm just mindful of time. I don't want to keep everybody over. So Gary, can you tell us of an inspiring or positive example of a collaboration with partners or communities you've seen in practice this year, because I know you're out and about a lot, that you think others could learn from?
Yeah, I can actually. I've got a current example that, whilst it's current, it actually goes back a few years. I'm working with a GP federation, and it's an example from that, but it could easily be a practice or a PCN doing this. So it's a GP federation that's started a collaboration that initially involved Healthwatch and a charity called Pilgrim Hearts, which supports the homeless. And they now provide a one-stop shop by a GP and a nurse, carried out at a homeless shelter that's run by the charity. And as I say, it's been going on for quite a while now. And I think it's a fantastic project that involves collaboration, supporting the homeless. And what they do is at a weekly drop-in, they provide a holistic care for the homeless there. They cover an awful lot of things, from medications to managing long-term conditions, and a whole load of things that the homeless wouldn't get access to very easily otherwise. And it's reduced hospital admissions, it's reduced prevented deaths as well. So all round, I think it's absolutely an inspiring one. And I can see this being done by any practice or PCN if they wanted to. Yeah, there's the challenges of the resource and everything, but I think a starting point is if you wanted to do something like that, is working with your local authority, your ICB, the local charities, and get your team, your partners, and your patients involved.
Brilliant, thanks, Gary. Not much to say about that, because that's fantastic. And I think the only thing I think from that is potentially a lot of providers are thinking, gosh, where are we going to find the time, or who's going to do that? And that's where, as you mentioned earlier, that sort of partnerships and communities role, or the with the local neighbourhood changes, hopefully that is something that we will be able to see a little bit more of in the future. And thank you. So last but not least, Ketan, sorry, I feel like you've had the more negative questions today. I'll change that for the next webinar. So the quality statement asks that staff and leaders are open and transparent. Can you recall a time that a management team either were or were not open and transparent, and what was the impact of this?
I can, and I mean, I think we've probably all got ones that are quite specific to our own PCNs or practices, but I think you had a really good example of the good and the not so good, perhaps during the pandemic and the vaccination program. Things I think were, the trust was built up fairly quickly when we all realized that we all had a common difficulty in delivering health and how we're going to manage a rapidly changing situation. So there were lots of briefings, lots of collaborative decision making, certainly going on locally, and that worked well. That built up trust, and decisions had to be made quickly, and those things really happened. However, whenever that changed, if another agency became involved, which was less transparent, it really showed, and it could have shone through, how then it muddies the water, because there's a different priority going on there, which is alluding a little bit to what I was saying earlier. And then suddenly, if you find that clinicians are finding out information from their patients, for example, because information has got into the public arena, for example, before clinicians are told, then that leads to an erosion of trust, and you're really not quite sure what's happening anymore. And then things can break down very quickly as well. So I think you saw all of that over that pandemic period.
Brilliant. Thanks, Ketan. Finding the mute button. Yeah, that's really helpful. Thank you. And I think that's my time up. So I will now hand over to Gary for the rest of the webinar. Thanks, everybody.
Thanks, Gabby. I mean, that was brilliant as always. I think no less daunting, but clearer. Certainly if I was in primary care, yeah, daunting but clearer. So thank you very much. Next slide, if we can go on to. In fact, actually, I'm just mindful of the time. So can we just go through to the process slide, if you would, for me? So 2 slides on, I think. That's it. Thank you very much. I'm just mindful of the time. We want to make sure we're introducing some questions and medicines management team as well. The well-led practice is something we want to just introduce and share a bit of now. So this is a digital platform that helps with not only your CQC well-led evidence, but also for the leadership development in the practice as well. Leadership development can be difficult to access in primary care for some, so we've created a platform that is able to be used by everybody in the practice and develop everybody in the practice. The way it works, and I'll use the slide that we've got here to explain, everything's done online. It's a digital platform, and it starts with a 360. So you can create a 360 for the leadership team or individuals in the practice, be that GP partners, practice managers, and also PCNs as well. There is a PCN platform as well. So it could be the PCN CD, PCN manager, or the other leadership roles. Everything's created digitally. It's all anonymous, completely confidential. You should create the link, share that with your team for them to feed back. They indicate the development priorities in a nice, clear, easy way using the friends and family test type smiley faces that we're used to. And they can also indicate areas that they feel are development priorities. They're asked to give a response to a series of statements in different areas that are all important for the CQC well-led domain. It's not an onerous thing that you're asking people to do. It takes about 5 or 10 minutes. So you create this, send it out to the wider team, and it's about 5 or 10 minutes for them to do it. You then get a report back, and the report that you get back is like you see on the center of this slide. And you'll get for every statement, every area, and every statement that you're asked them to respond to, you get a score. If you can see this, it might be a bit small, but there's a blue bar, and that's the self-assessment element of 360. The pink bar is the wider feedback from the team, and we also benchmark against our database. We've got a number of practices and PCNs now that are using this platform, so we also give you a benchmark against our database. Green circles on the report, and you're in the top 10% of our database, and the red circles, one red circle that you can see there, that's in your lower 10%. And the report is going to indicate by the lower scores, but also the red circles where you're showing in the lower 10%, is going to indicate your development areas. Now from there, we provide a template to create an action plan, because the next step would be to use the report, create an action plan, and build your development using the expert guidance library that you see on the right. We point you to lots of activities that you can use. Ben, next slide. I'm racing through this. I'm just mindful of the time. Now, the sorts of questions that we'll ask, if we take partnerships and communities as an example, you'll see on the slide here. And for each of these questions, if it comes up as a development need, we point you to exercises that are in our expert guidance library. Typically, the exercises can be 20 minutes and they can be up to 2 hours. That would be a long one. Probably 20 minutes for an exercise you do individually, and an hour as a team is about the average. But you get a huge library of different activities that you can use. We can go on to the next slide. Okay, so the pricing of this, we do flexible subscription plans now, so you can have monthly subscription plans, annual or 2 yearly plans that can start as little as 10p per patient. We price them per patient. As well as getting a plan that you get access to everything, you can actually buy just 360 reviews, and they start from £350. Our pricing is all transparent and it's on the website for you to see. If we go to the next slide. Okay, we also provide a whole host of other services where we facilitate workshops, we'll provide mediation, we can do a full CQC inspection service, and we also do a board review as well. Again, these are all on the website. And the next slide, I think, comes to questions. Now, I'm afraid because of time, we're going to answer your questions on email.